Welcome, everyone. Appreciate everyone coming and joining for our latest webinar in our webinar series. I just want to give you a little information here on the CME. So there is CME credit available for this, and we have posted also the disclosures on our slide. We will be sending out an evaluation to all attendees to have that completed as well. And then your CME will be sent to you from Des Moines University. So we, again, appreciate you joining us. We have a great speaker to talk about IPOST, and he will be sharing his screen in just a moment now that I've stopped my screen. And we're just very, very excited to have him. It's Dr. Tom Mosier. He's the Chief Medical Director for Every Steps Care and Support Services. And so he'll be giving his presentation, and then there will be time at the end to answer questions. If you do have if you have questions during the time, feel free to put them in the post in the chat also, and we'll just address those at the end. So I'm going to turn it over to you, Dr. Mosier.
Great. Thank you very much. So welcome, everybody. Thanks so much for attending. And just a little weather bulletin for you, as April showers do yield May flowers, but sometimes a little rougher than others. If today, by chance, any warnings get called in your area, riveting as this talk will be, please feel free to seek shelter. And it is being recorded, so you can always pick it up later and tune in later. So, and definitely we'll be taking questions at the end. And hopefully there's something that is helpful to you along the way here. So getting started, as it is National Healthcare Decisions Day, it's a very appropriate topic to talk about, and that is IPOST and advanced care planning. And so to kind of key things off, I want to talk a little bit about what has been going on in our realm over the years. So nationally, if you look at data back as far as you want, about 70% of Americans, if you ask them if you had a terminal illness or felt to have a disease that was in its end stages, would you prefer to be at home when you pass away? And would you prefer to be at home more than in a hospital? You're going to get a very high number of people saying, absolutely, I want to be able to die at home. Yet, when you look at data over time, you'll see some striking things. Number one, only about 25% of Americans actually realize that hope or that goal to die at home. And number two, as we go along in time, as we become more robust, more evidence-based in our practice, more connected in our healthcare organizations, we find that hospitalizations in the last 6 months of life are actually going up, not down, which is a little bit contrary to the goal of what people say they would want. We also are finding that it is not uncommon at all to have 10 or more physicians involved in any given patient's care during that last 6 months of life, which is somewhat striking, right? And then lastly, when you talk to Americans, most don't have an advance directive. When I talk to them and ask, you often will get people saying, I think we talked to somebody about that once upon a time, but if they did, they don't know where it's documented. And certainly then their providers and physicians that are at the bedside often are not aware of that advance directive and don't have it to direct them. So we have definitely some systemic issues going on that make things very challenging. So here's another lens to look through. What do doctors do compared to the general population? And this study put out by Wiseman et al. Showed some striking things. And that is that doctors tend to die in the hospital less often than non-doctors. And if you think it's related to just educational level, maybe being just more aware of how the world works because they're more learned, when compared to lawyers who have equal amounts of educational experiences, right? They die less in hospitals. And they're often much less likely to have aggressive surgeries to escalate to the ICU. In general, doctors don't throw a lot of Hail Marys when it comes down to their own personal health care. They tend to choose differently. This is another study that's fairly fascinating that highlights that point. This study was done by my mentor and program director, Vijay Pericoil, out at Stanford. And she looked at two academic hospitals, both Stanford University and another in the California Bay Area. And they polled 1,000 doctors crossing all subspecialties. And they asked them some questions about, number one, their value of advanced care planning. It was kind of a pre-post look to an earlier study that was done prior to the Patient Self-Determination Act of 1990. And they wanted to get a sense for, since that time, had doctors changed their view of advanced care planning? And then also get a window into, if you, the doctor, were told that you had a illness that was chronic and likely terminal in the next months to year, would you want to be full code or DNR? And what was fascinating is that the vast majority of physicians stated they would want to be DNR. They would not want resuscitation if they went into cardiopulmonary arrest. And yet, this is in stark contrast to, I'm sure, what you've experienced when you talk to patients about the same. Sometimes the most sickly patients who have the worst odds of any meaningful recovery. Sometimes even people who literally say, I want to be on comfort care only in hospice, but I want to be full code. We look at that and we're a little unsure of even what to say, because we know in our heart of hearts, we would not do that. But we don't really know what's prompting them to want to do that, right? So ultimately, there seems to be a very discordant path doctors take from what they might allow their patients to take, right? And we do know, right? All of us want patient-centered care. All of us want the patient's choice to be louder than what we think. But there is often a disconnect there that I know I can feel, and I know I've talked to plenty of colleagues that they can feel as well, where they're just not quite sure what their patients are thinking with regards to their choices. Let's look through a different lens. Let's look through the lens of hospice now. So this is data from CMS. And at any point in time, you can look at this. In 2016, the data looked very similar in that the average length of service for the Medicare beneficiary on hospice was around 90 days. And so if you look at that number and you think, well, to be on hospice, two doctors need to feel they're likely in their last 6 months of life if the disease follows its normal course. Well, 90 days, that's not so bad. We're calling it pretty good. And when you see it's about average 50% of Medicare beneficiaries, it makes you feel like, okay, we're making some progress. We're not nowhere. We're not nowhere land. But if you look into the data more, you'll see the median length of stay is 17, 18 days. And actually in 2016, it was 22. So we're actually going the wrong direction. We're going down there. And if you focus in on that, you'll see we are dealing with a very skewed distribution. And if you zoom in more, you'll see we're really dealing with a pretty stark bimodal distribution, in that the vast majority of people are on hospice for extremely short lengths of stay, sometimes just hours to a day. And then there's another population of those patients who are elderly, who have defied all odds, right? Maybe not having a lot of medical illness, not a lot of chronic medical comorbid conditions, when they made it to 100 years old, right? And they decline and they come on hospice and they live extraordinarily long times, sometimes on the order of years on the hospice benefit before they pass. So they buffer that number out. But it's not uncommon to see extremely short lengths of stay. So now let's make it personal. Let's look at some real Iowa data. So our organization covers about half the counties in Iowa. And at any given time, if I poll our average length of stay, it is a very small number. And in fact, for an average daily census, when I pulled this data a couple of years ago of around 240 patients a day, we would see more than half of our patient population turning over every 60 days. And in fact, the vast majority of that population was turning over just days to weeks. So ultimately, we continue to see very, very short lengths of stay. Fast forward to today, I just had a meeting last week with other senior leaders, and our average daily census continues to go down year after year in spite of our number of admissions statewide going up. So we're serving more people, but the length of stay is shorter. And that does show then that there is compression of morbidity and mortality, that we are seeing people literally being referred later and later. And from a standpoint of hospice care, that's really sad because ultimately it's really, really hard to truly benefit from the robust services that a team can provide to a patient and their family when you literally have to condense that into hours for that impact. Let's look through another lens. So this is some data from Dartmouth that they compile tremendous amounts of data on every state, on every health system within the state. So if you want to drill into this more, I encourage you to go to the website listed at the bottom of the slide here and take a peek. But I took a screenshot of the upper echelon of what we call the HCI percentile, the hospital care intensity. And what they did is they kind of compressed into number of hospitalizations, number of providers, the billing, and all of that. And they were able to tabulate a sense of how much intensity time in the hospital people were spending at end of life, okay? And as you can see, the states that are the highest are those states with high population centers with lots of health systems, right? And also states with high numbers of elderly patients like Florida. So you see New Jersey, New York, Nevada, Texas, California. They're on the upper end of this where their costs and amount of time spent and amount of intensity in the hospital was tremendous when people were dying. And let me just preface, they weren't dying unless and they didn't have a longer life expectancy, and they certainly didn't have a better quality of life, as one can imagine, when they're in the hospital getting the kinds of care that they're needing. This map gives another view on that, and this shows through color coding that pretty much a line from Michigan down to Texas and east, there is a tremendous difference in hospital intensity at end of life. And then also you've got California in there. The central United States, the rural areas are much lesser. And in fact, you'll be proud to know that on that list that went for pages and pages and pages that I screenshot, Iowa was 8th from the bottom. So we're not doing nearly as poorly as far as IC index, but ultimately there's always room for improvement, right? There's always low-hanging fruit. Here's another view. So let's look at total reimbursement per patient during the last 2 years of life. And no surprise, those same states and health systems that were involved in the first slide are the most costly. So up to $237,000 per individual in the last 2 years of life. So in other words, one can see a window into the lack of quality and efficiency, right? We're spending way more time in the hospital, driving costs through the ceiling, and ultimately, what are we getting for that? But take a look at this. Number of physicians involved in the care in the last 6 months. So now let's not look at the last 2 years. Let's look at the last 6 months of life. And it's no surprise, New York, Texas, New Jersey. And if you scroll down, you'll start seeing the California hospitals. Ultimately, those same health systems or states with the high cost and the high hospital utilization are, on average, you'll see 15 to 20 physicians per patient involved in their care, which really should make us pause for a minute, right? If our job as physicians is to provide our absolute best to the patient towards their goals, their health, their quality of life, and their satisfaction, ultimately, you would think that if there's 20 physicians involved it should be through the stratosphere, right? But it really is the paradigm swing of less is more, right? Because ultimately, the more people that are involved, it seems to me to be that the more fragmented everything seems to be getting. And then this data point, percent of deaths occurring in the hospital, and surprise, it's the same areas, the same health systems. So I think these slides really illustrate something quite profound. And that is, there is a problem in how we are delivering healthcare, in our strategy for healthcare. Something is happening that is skewing and driving things the wrong direction outside of what the average American tells us they would view as quality healthcare. So what is it that's happening? And we could talk about whole lists of things, but in general, a few things that come to mind for me. Number one, care fragmentation. Anytime you have high density of health systems, competing health systems, right, that are putting up their silos and strategically as organizations trying to work within themselves, anytime you have differing charts, anytime you have market share being fragmented, you have the opportunity to fragment healthcare for the consumer, right? Ultimately, if you go to Methodist Hospital today and you get great quality care, and tomorrow end up in Iowa City, the right hand very well could not know what the left hand is doing, right? You could literally have a very appointed goals of care conversation at Methodist Hospital today, document it very well in your chart, and they end up across town at Mercy, and we start from scratch and nobody has any idea. Or you could end up back at Methodist and nobody comes across the note you wrote that was so eloquent, right? There is tremendous opportunity for fragmentation. Within that fragmentation, it's very easy to not identify trends, right? If you every single time are not seeing the patient, if the same doctor, if the same team, if the same rounder, if the same service isn't always seeing the same patient, you don't necessarily connect the dots from one time to the next. You don't see the most important prognosticating piece of information, and that is the change over time, right? The trend trajectory. So ultimately, with this fragmentation, it's not surprising that you would see people not being identified as near end of life, right? In these high populous centers where they bounce around and where there is all that fragmentation, it's very easy to lose track of the forest through the trees. On top of that, we run into another issue, I believe, with fragmentation. That is, everybody else thinks somebody else will do it, right? We think somebody else surely has talked to them about what to expect going forward. Somebody else has surely had that goals of care conversation. And that comes from a couple places. It comes from assumptions. It also comes from a little bit fear. Let's be honest, every single one of us has been in that scenario where we are like, boy, I don't know if I'm the one who wants to bring this up and speak to the elephant in the room, right? What if they get upset? What if their family gets upset? What if they cry and get emotional? What if I don't know what to say and I'm clumsy? I don't know them as well. Somebody who knows them better probably would be the better person. Or lastly, the thing that we all can't help but think about, time. Oh my golly, I'm super busy today. I don't think this is the day. I don't think this is the clinic visit. I think this could take an exorbitant amount of time and I just don't have it to do justice. Out of respect for them, I don't want to rush it and make them feel like I don't care. And so we kind of kick the can down the road. Let me give you an example of that occurring. Several years ago, certified a patient for hospice to come to our hospice house. And that patient was on CVVHD due to acute tubular necrosis. They basically had bladder outlet obstruction leading to urosepsis and ultimately had sustained significant kidney injury. They were on CVHD, and unfortunately, their blood pressure was not tolerating it. So nephrology called palliative care in, and ultimately palliative care talked to the patient and family about hospice. And the patient capacity was a little off, so the patient was involved in the decision, but not remembering it very well, because the next morning, after they were in our hospice house, I get a call that I am to be front and center with a very angry patient. And so I went to the bedside to scope out what was going on. And what the patient told me is this: what in the heck is going on? Yesterday, oncology came and talked to me and told me that I had prostate cancer, but I was more likely to die with it than of it. I set up an appointment to see them in the outpatient setting to start talking about therapeutic options yesterday. 3 hours later, I'm transported to hospice and told that I'm dying. What on earth is going on? Well, as it turns out, what had happened is different subspecialists rounded at different times, different places, times and space, right? Like typically happens in the daily affairs of rounding. And nephrology came in, and from their perspective, things were pretty bleak, right? The patient was terminal. There was nothing more they could offer that would change that. But oncology came in and stayed in their lane and spoke to the cancer. And it happens a lot. It's not intentional, but ultimately, the forest through the trees was lost. Not everybody was on the same page. And that fragmentation led to a patient not only being very confused, but being set up for massive regret in the decisions that they made, because there wasn't clarity going on. So I want to now shift into an example of this and how this happens on a larger scale than just situations like that. How this might happen when well-meaning we walk in at admission and establish code status, right? Mr. Jones, while you're here in the hospital, heaven forbid things don't go well and your heart stops and or your breathing stops, do you want cardiopulmonary resuscitation, right? And we go into that and we document code status, we place the order, and we go on with our day. So watch what happens with this example. If I were to ask you what your preference was in getting from point A to point B, would you tell me you would prefer to drive on a road that looks like this or this? Or would you say, no, I would rather drive on a road that looks like one of these later three? Now, it's kind of a rhetorical question almost, right? I've given this example countless times over the last 13 years. Hopefully not too much. If you've heard it before, I apologize, but I think it's important. I've never had a single soul tell me the later three. Everybody unanimously raises their hands the first two. So now we're going to take it somewhere interesting. It's helpful that I know what you want, because I'm going to use this to help you. You see, you live in Iowa and you just were told that your father, who you love dearly, who lives in East Lansing, Michigan, has been in a serious car accident, and he's not expected to live more than hours to days. And in the whirlwind of this terrible news, you need some help. So ultimately, the good news is I know what your wishes are, and I'm going to get you a bus that is going to bring you on the most gorgeous scenic route I can come up with on how to get to East Lansing. It's going to bring you through Wisconsin, which I love driving through, the rolling hills, up through the Upper Peninsula of Michigan, across the Great Mackinac Bridge, a 5-mile suspension bridge, through northern Michigan, which is gorgeous, all the way to about Mount Pleasant, Michigan, where it gets a little flatter and not quite as foresty. But it's a beautiful drive. Now, on a good day, that drive is about a 15-hour drive if you don't go to the bathroom and if you don't hit a deer. But I knew, based on how quickly you told me what you wanted, you did not want to go this route. This route through Joliet, Gary, Indiana, as you can see from the screenshot of MapQuest, the road hazards are always there. So ultimately, I was able to avoid that for you. So now I have a question, and that question is this: are you happy with what just happened? Or would you have regrets about what just happened? Ultimately, again, I have never once had a single person be happy with what just happened. I get 100% discordance from what was so unanimously attractive and appealing and seemed right. And I would ask, what is the difference? How did that happen? And what I would say happened is, number one, I didn't tell you at all what we were making decisions about or how this was going to get used. I didn't give you any context, right? I didn't say if you had an emergency for yourself or in any other way, and you had to get from point A to point B, what would be most important to you? I just asked you something that kind of snuck up on you, right? Not on purpose, but nonetheless, it did. I didn't have any context. I also didn't get your values. Had I known that you loved your dad so much, if you could get there faster, you'd swim across Lake Michigan, there might have been a different conversation, right? But ultimately, I left those things out. Now, in this example, I did it on purpose. In everyday life, we don't do it on purpose. When we ask Mr. Jones about code status, what we often forget is pie in the sky. Nobody wants to die. Everybody's afraid of what it would look like to not get CPR. Does it mean I suffer? Do you just walk away and stop providing medical care? Mr. Jones, there was no discussion about how his heart status, the outcomes of that may be, right? If Mr. Jones is a nursing home resident, 2 out of 100 will actually survive that cardiopulmonary resuscitation attempt. If he was an all-comer from the community with no chronic medical conditions, about 30 out of 100. So ultimately, Mr. Jones has no construct, right, of context. We don't understand what he knows and what he doesn't know. And so therefore, we potentially set him up. Now, here's the pitfall. If we go into every single patient's bedside and try to ask them all the specific scenarios that could play out, we will spend all day and all night. Imagine the conversation trying to ask Mr. Jones about if he would ever want dialysis or pressors or IV antibiotics and explaining how IV antibiotics might be more efficacious than PO in certain circumstances, or non-invasive ventilation versus ventilation and all the things that come with it, right? Sedation, ET tubes, that kind of stuff can get us into the weeds very, very quickly. But what if instead we ask Mr. Jones these 2 questions? What abilities are so critical to your life that you can't imagine living without them? And what if he said to you, my family is the most important thing, and I don't want my family to go through hell and back over what happens to me, and I don't want them to worry about me. And frankly, I hardly ever see my family anymore because I've been living between the hospital and the nursing home, and I barely ever make it home. And doc, I'm not alive and not living, and I'm not sure I want you to do too much if it's going to threaten my ability. Or what if he says, if I can't be myself, if I can't talk, if I can't think, if I don't recognize my family anymore, life's not worth living. Or if I can't eat ice cream and watch football, just put me in the back 40, right? So when I ask people that question, I can get to the meat of what is important to them. I can cut through all the scenarios very quickly, because then I can filter through the scenarios that are most likely and what that might mean and pair it with their values and not get into the weeds near as much. Same with this question. If you become sicker, in spite of everything that we're doing for you, how much are you willing to go through for the possibility of gaining more time? When you put the question that way, people suddenly get what you're asking. And again, it can cut through all of the details and fixings that get us so bound up. And we can get to the heart of the matter, that ultimately we can see what they value. We can see their fears. We can start to then put some frameworks around things. And then you can easily go back to those clinical specific scenarios and say, one of the things that I have pause about is that you're very sick. As you well know, you've been spending more time in the hospital than at home. You mentioned that to me. If, in spite of our most aggressive things, your heart and lungs were to stop, sadly, only about 15 out of 100 people will survive, and the vast majority of them will end up in a nursing home and likely die in the next 6 months. It doesn't sound like that would be something that you would want. And you can very quickly then get to a much better decision than them choosing full code because they don't know what they don't know. So now is about the time you say, I thought this was a talk about the IPOST form. We haven't even said IPOST yet. So here's where the IPOST comes in. This form is then where that conversation gets documented. This form is not necessarily the scripting or template for that conversation. It can be after you've gotten some of those values and goals. You could go back and you could work through the form. But boy, I would caution you to start talking about code science in box A. The form is arranged to be helpful for the user, us, in emergencies or when we need to make rapid decisions, right? So a paramedic really needs to know when they show up if they do CPR. But obviously, the first thing I ask a patient isn't that. It would be, what are the kinds of medical interventions they might want? What I've heard you say, Mr. Jones, is I think you would fall in this bucket based on what you've told me. Tell me if this sounds right, and then read some of the interventions and explain what that might be paired with their values. And then say, Mr. Jones, if in spite of all of this care, your heart and lungs fail, and you're found without a pulse and not to be breathing, at that point, do you want us to focus on comfort or on resuscitation, even though the outcomes aren't real good, like we talked about? So there's ways to key this up. The most important point being the IPOST form is a portable medical order that is actionable for the patient, but it isn't the template. The checkboxes themselves can be problematic. It's a powerful tool. It's a powerful tool that can cut through fragmentation because it can follow them through all the different healthcare situations they find them in, through the different healthcare organizations. It can literally follow them from Methodist Hospital to Mercy to Iowa City. It can follow them to the nursing home. It can follow them anywhere. So it's a defragmenter, and it documents that detailed conversation, but as a power tool, it is no different than this power tool. I happen to be a woodworker, and with my cabinet saw, I can do amazing things. But my brother-in-law, who's an ER doc, can attest to how he interferes with natural selection on a frequent basis with power tool injuries, right? Because they're dangerous. Things can happen very easy if you don't know what you're doing or if you're careless with a power tool. And I would say to you that the IPOST, just like this power tool, can be dangerous. Let me give you an example of that. So a couple of years ago, my boss asked me if I could help out with a family friend that he knew. Their daughter, sadly in their mid-40s, had been diagnosed with ALS. And they called and said, we need some help. And he said, hey, I can send Tom up and see if maybe he can help figure out how to help. So I go up there, I knock on the front door, and mom and dad greet me. And before the door even opened all the way, I saw what they were holding in their hand. They were holding a salmon pink cardstock form that said IPOST. And that form was blank. And they said, we were given this to fill out. Well, we don't know what we don't know. And our daughter doesn't feel comfortable filling it out. We're wondering if you can talk to us about what this is and about what all this means. The patient had at that point lost the ability to communicate except using one of the eye tracking machines, but uncannily was able to be very articulate. And what she was able to communicate is, when I got this, I was inclined to check the most aggressive thing on every box because I didn't know what a lot of it meant. But it occurred to me that might not be in my best interest. And so I thought I better ask. And then started to ask things like, what is BiPAP? What is CPAP? What does mechanical ventilation entail? Does my disease state have any relevancy to mechanical ventilation? Do I need to be worried about it? Well, for all of the clinicians listening, right? That's like, wow, right? But it shows patients don't know what they don't know. She didn't know that the most likely thing she would die of from ALS is respiratory failure. And that, yes, ventilation is a really loaded topic when it comes to ALS. And so we were able to talk about backing the card up, what's important to her. And she was able to say very articulately where she would draw the line and why. And so then we were able to revisit that conversation and talk about the things that come up with ALS care, what the pros and cons to ventilation, ventilator-associated pneumonias, recurrent hospitalization, quality of life, potential to have to maybe live in a vent unit or move if living on a ventilator in the home was too challenging. Ultimately, that helped her make a really good decision, and she was then able to confidently have me help her fill out this IPOST and sign it and put it into action. So ultimately, it's something I've come across not infrequently in an attempt to utilize the form, particularly in post-acute facilities. A lot of families are handed an IPOST, a lot of patients are handed an IPOST and say, go ahead and as part of our admission process, can you fill this out? And what I'll tell you is 9 times out of 10, that form, therefore, it's as if they didn't have a form done because they typically default to the most aggressive on everything. The other pitfall I see is this: the form being used for the patient it's not appropriate for. IPOST is appropriate for a patient with serious illness, chronic disease, that you wouldn't be surprised is in their last couple of years of life. You wouldn't be surprised if a medical emergency surfaced. Definitely not something that you want to fill out with your mid-40s who's healthy or your teenagers, etc., right? So we want this form to be utilized for people when it's appropriate in their journey, in their healthcare journey, when it's going to have the most utility. Okay. All right. Where did it come from? It's called the IPOST. It has Iowa in the name. Is it an Iowa specific thing? The answer is no. So this actually was a movement that began in Oregon in 1991. The goal at that point was to elevate shared decision making, right? So through like the ask, tell, ask model, which we'll speak to again in a minute, tell me what you understand about your illness and where you think it is likely going. After they share, would it be okay with you if I shared some details of my understanding after talking with your treatment team, reading through your history and evaluating you? Bridge those gaps, right? They may have no idea. They may be totally off base. Help fill that in with permission. And then when you're on the same playing field, after hearing this, tell me what's most important to you. What do you think the next steps are? And carrying the conversation forward. So we call that shared decision making, right? Because it truly is shared after we've leveled the playing field. And then being able to document it in a way that honors them and achieves the outcomes in a defragmentation tool that can span across the health continuum. So Oregon started this, it quickly spread to other states. Here's a map, current state from POLST.org. And pretty much every state does have a form in varying degrees of, um, of effectiveness. Some in early inception, some that have been doing it for years, hence the color coding. We would love to see systematic movement towards interstate portability and databases where you can look it up quickly, but I think we're a ways away. And this gives you a sense of why that might be. Every single state has done it a little differently. They take the template, they all look very similar, but there's different wordages, there's different processes, there's different legality. This is just a smattering of the different names the form might have. So in comes another interesting story. Good friend of mine, ER physician in Texas, called me one day, said, hey, Tom, I need your help. I got this situation going down in the ER. And I just need some palliative care expertise. I'm not sure what to do with this patient. Family doesn't really seem to understand. I'm just really worried going forward. And I said, boy, it sounds like a POLST-like form would be really helpful. Do you have a POLST form in Texas? And this was like 2 years ago. He's like, I have no idea what you're talking about. No, we don't. Well, I looked it up, and sure enough, they did, and it was called MOST. And this is the form. And as you can see, it's very similar to our form, organized in a similar fashion, section ABC, similar things it speaks to, but different wordages, right? So ultimately, what that told me is this: just like in Iowa, they have a form, it's legal, there's a process, but the most important end user of that form, the provider, has no idea it exists and would be very liable to hand it out to the patient to fill out themselves and achieve essentially nothing other than a great attempt at trying to utilize the form, right? So the POLST paradigm movement is really about a portable medical order that is filled out after a conversation, and that conversation is high quality so that the output on the form is high quality, and then wishes can be honored. And so in Iowa, as we began our journey with this forum, we had the same vision and mission, which was something that could go across the healthcare continuum. Again, my wordage, a defragmentation tool. It's the only thing I know of that actually can easily go between health systems, right? And charts. And so, for about 12, 13 years now, we've been on this journey with a form that was legalized in 2012, and yet we still have varying degrees of understanding about what it is, how to use it, how to fill it out, what's the legality behind it. We still have a long ways to go. So this form, in the end, can be very, very powerful. But we still have yet to realize, I believe, its full potential in our state, because we really need to get word out that truly anybody can fill this out. So I've actually just had a bunch of nurses and social workers go through a training through an organization called Respecting Choices to help them learn how to have these high quality conversations so that they can help fill out these forms. And then a provider, myself, a nurse practitioner, OPA, then can sign it into a medical order, right? So it's actionable. So I think that where we're kind of stuck as a state is still in that process, implementation, and rules and legality standpoint. But we also easily get stuck in the conversation standpoint. So I want to shift gears to that now and hopefully provide something that will be the penultimate resource for you going forward as you have these conversations. And this was something put together by Admirandi Labs, which was a multidisciplinary group of people that put together scripting and tested that scripting over time to hone down and boil it into some very poignant and well eloquently written questions to help navigate the conversation. And it only takes a couple times to recognize how much power these questions have, okay? From top to bottom, Mr. Jones, I'm hoping we can talk about where things are with your illness and where they might be going. Would that be okay with you? Wow, what a way to engage them and respect them and to make sure you have their permission, right, to go there. And then, what is your understanding now of where things are with your illness, and how much information about what is likely to be ahead would you like from me, right? Again, opening that door of respect in a way that just is not off-putting to anyone, okay? Or I'm worried that time may be shorter. This may be as strong as you feel. And so it's really important to me that I know what kinds of treatments you would want going forward based on your illness and what I expect or what we expect as your treatment team. What are your most important goals if your health situation worsens? What are your biggest fears and worries about the future? Boy, if they tell you, I'm worried I'm going to end up in a nursing home, or I'm worried I'm going to bankrupt my family, suddenly that helps you know the framework that you need to speak to some of these therapeutic options. What gives you strength as you think about the future of your illness? What abilities are so critical to your life you can't imagine living without them? If you become sicker, how much you're willing to go through in order to gain more time? Does your family know what your priorities and wishes are? Because this is something that often is very helpful to them. So ultimately, you don't have to ask every single question, but you can see that you could very quickly tailor and navigate into a very powerful conversation, not talking really any medical specifics up front, right? Not getting into pressors and units and all of the technicalities that we all spent 10 to 15 years to learn about, right? So ultimately, this conversation guide is what I use as a palliative care physician. These questions work for me. They're my go-to. There's no reason to come up with anything different when they work so well. These next couple slides, I just highlighted them out bigger so you can see them, and you can also see that there's some suggestions in parentheses on some of them. And then ultimately, if you kind of draw a blank somewhere in that conversation, I want to go back to the ask, teach, ask, or ask, tell, ask model. So this spikes protocol was a protocol we used in fellowship, right? Where we would kind of systematically go through, but if you boil it down, kind of aligned with those bullets, really it comes down to this. Mr. Jones, tell me what you understand about your COPD. What it means for you. Tell me what you understand we're hoping to realize with treatment of your COPD. Tell me what you understand about your prospects of being hospitalized downstream. Tell me what you understand about the trajectory of decline with COPD, whatever you want to ask. Then listen to what they say, because you will quickly identify if they really truly understand or if there's gaps. Next, would it be okay with you if I shared with you my understanding or filled in a few gaps of things that you had questions about? And then, having heard that and knowing what you said is most important to you, what do you think the next steps are for you? And that's when you can literally take the patient who said, I will sit and talk with you, but if you say the H word, I'm gonna walk out. And you can literally say, oh, I gotta say the H word. But boy, one of the things that strikes me is how much everything you said aligns with what hospice can provide. Would you like to know more about what they can provide, right? And so that's the opportunity. And I've had countless times that patients are hugging me and thanking me I had that conversation, even though at hello, they weren't real pleased talking with the palliative care physician, okay? So ultimately, ask, tell, ask is a great thing to fall back to just guide your conversations as you go. When you do that, focus on open-ended questions. We all have a tendency to want to be closed-ended because we don't want the soliloquy, truly, right? We don't have a lot of time for the soliloquy. But open-ended questions really will help you know what they know. If you just ask them, well, tell me, do you understand what COPD is? And they say yes, you really have no idea what they understand. So it's important to stay open-ended. And then there's a couple ways you can guide things when you get stuck. You know, when people are really holding on to something, like maybe going to the ER every time they decompensate, even though each time there's not a lot more you have to offer, or maybe it's dialysis, or maybe it's tube feeding or TPN. To really reframe those questions. What do you think would happen if you were to stop coming back to the hospital? Explore, maybe they have some fallacies about what that might mean, or if you were to stop TPN. I had one patient I got consulted on that was eating chicken dinners and broccoli, wouldn't let go of TPN, and the surgeon called me and said, can you help? We can't get her to agree to go home. And she's been on TPN for 2 weeks, and her BMI was 36, and she was literally eating chicken dinners. And so I just asked her, what do you think would happen if you stop TPN? And she said, well, I'll die. It's keeping me alive. Whoa, we identified a big gap right there, right? By the end of a very short explanation, bridging that gap, she said, well, what the heck am I doing here? Get me home. It was a Friday. I had that conversation on the telephone with her, right? Kind of like a curbside consult. I couldn't make it out to the hospital, but I jumped on the phone. She was transferred by Monday morning. She was already in a facility doing skilled rehab. So it's amazing sometimes how a pointed question can cut through all the clutter. Or what benefits do you think might come from stopping TPN? Right? She identified, well, if I wasn't on it, I think I could go home. They told me that's why I have to stay here. Right? So we used a little bit of both of those reflexive questions. Ultimately, then, the important thing is that conversation certainly can be dropped in a note, but documented on that IPOST form. Make sure the IPOST form is updated. On the back, you can see at the very bottom, you can type in when it was reviewed, when it was updated. You can take the old form and shred it and fill out a new form and replace it if goals change. You can use copies, but typically we recommend the master goes with them because it's easily identified and a little more hardy and cardstock, right? So here's then the million-dollar question. Does it work? Do these POLST forms work? And so here's an interesting study that's fairly recent that was just published within the year. And they looked at retrospectively over 1 million nursing home residents in California. So California is doing a big push to make sure there are POLST forms. They call it the POLST in California on their nursing home residents, right? Population very likely to matriculate back to the hospital and have recurrent hospitalizations in spite of being very sickly, and maybe having goals that aren't congruent with those recurrent hospitalizations. And so the POLST has been something that has been really encouraged. And what they found was when they looked back, residents who had a POLST that was completed and who specified DNR comfort care, on average, were spending 56 less days in the hospital and 22 less days in the ICU. And they also found that patients who didn't have a POLST or didn't have a signed POLST or filled out the POLST themselves, the value wasn't really there, right? Which isn't too surprising. I know not only that, but from my own experience, as I've had these conversations and I've filled out IPOST forms, it has meant the world to those patients and families because I often hear, where on earth has this conversation been this whole time? Today, we accomplished more than we've accomplished in the last year of doctor's visits and subspecialty visits. And thank you so much for having this conversation. So I would say this in closing, in this era of evidence-based medicine, I would submit to you that we have more than sufficient evidence that more hospitalizations, bigger treatment teams, more pharmaceuticals don't actually carry power for people with serious illness and chronic disease as much as sitting down with them, identifying what they don't know, what they think they know and don't know, helping bridge the gap and helping guide them to the treatment options that you or I would most likely pick if we shared their same goals. In other words, to not let them pick things that we cringe at when we leave at the end of the day because we know better, right? So ultimately, more powerful than the biggest of health systems is one provider and one powerful conversation utilizing something that can help defragment, such as the IPOST. I hope this helps you in knowing how to use this form and knowing how to have those conversations. And I'm definitely open to any questions if anyone has them.
Yeah, thank you so much, Dr. Walker. That was really interesting. Yeah, open it up to the group. Does anybody have any questions? We have a few minutes left. Feel free to unmute and ask your question.
This is Noreen O'Shea, and I have a question about portability across state lines. Is if I have an IPOST filled out for me or for one of my patients and eventually goes to live in Minnesota or Nebraska or South Dakota, how portable is this? Is it recognized with my signature, even if I don't have a medical license in one of those other states?
Great question. So from a legality standpoint, there are some states that have established portability, but very few. And I do not believe any of our neighboring states that we're in that bucket. What I would tell you is this, though, if a patient from Missouri brought to me their form of a POLST form and handed it to me, although it's not actionable for the paramedic, it certainly is actionable for me because it tells me everything I need to know. And I might just reestablish quickly, boy, from reading this is my understanding about the kinds of treatment you might want right now. And it really fast forwards the process of me understanding what their needs are. And certainly could be used equally with family. Boy, and looking at this form, this is what I'm seeing. And did they talk to you about this? And it can get you caught up to speed very quick. So I would say the utility is still there. The legality for nurses, paramedics, et cetera, as far as following it as actionable order is different though. So in the hands of a provider, it probably would have a little bit more impact than in the hands of a non-provider who needs to have a legal order. That's a good question. Any other questions?
Okay, well, thank you again, Dr. Moser. We really appreciate your time and appreciate all the time of those of you that have joined. And we hope that you have a good rest of your day. Thank you.
Thanks, everybody.
Thank you.